Kia ora koutou katoa. No mai, haere mai. Ko Christopher Dawson toku ingoa. Hi everyone, welcome. My name is Christopher Dawson, and I have been involved in the field of telemonitoring here in Aotearoa for several years, developing telemonitoring technology with Spritely and working with healthcare providers to plan and deliver telemonitoring programs that address health inequities in New Zealand. Thanks for having me here at HiNZ Digital Health Week. I'm here to talk about equity-led telemonitoring, which is without doubt an important topic for discussion. The new health reforms explicitly call for more care to be delivered over data and digital in the community and at home. The reason for this is to improve efficiency for staff and access for patients without negatively impacting health outcomes. If patients can be looked after at home without any worse outcomes, then it makes sense to develop models of care to enable that. That's where technology can be a game changer. Treatment plans can now be actively managed by clinicians at scale. They don't have to treat people in a hospital or a clinic where there is limited space. They don't have to drive to visit them, using up valuable time in transit. Consultations, including visual assessments, monitoring of vital parameters, tracking symptoms, titrating medication, and a whole range of other things can be done remotely. And this brings huge advantages to patients and clinicians. But unfortunately, without equity-led telemonitoring systems, not everyone will be able to enjoy these advantages. If we don't focus on equity-led telemonitoring and make that a priority, our push to deliver care closer to home using data and digital will inevitably drive up inequity in the health system. People that have poor access to healthcare now have worse outcomes. If we shift that care to be delivered over data and digital, then people with poor access to data and digital will have just as bad outcomes in the future. If we really want to improve outcomes by resetting access to healthcare, then we need to develop new models of care using data and digital that anyone can easily access at home or in the community. So, over the next 10 minutes, I'm going to talk about equity-led telemonitoring. What is it? Why it's important? How it fits into the new reforms? A very short example of where we're seeing it happening, and a brief discussion of when or what conditions might enable it to scale so we can start to address some of the most pressing health equity issues for more and more New Zealanders. First, what is it? Equity-led telemonitoring reimagines how disadvantaged priority populations can benefit from the advantages of remote care in their own home. The key to equity-led telemonitoring is a fully managed device kit, enabled with 4G, so people don't need to own their own smartphone or other connected devices with all the associated data costs. It can be a massive barrier to participation. At Spritely, we co-designed our fully managed device kit with older people who had little or no experience with touchscreen devices. So now, even when patients have little or no experience with touchscreens, they can still easily use the device to support their health. The system can be delivered in a box, and it works as soon as the patient takes it out. And that's important because there is no setup required by the patient. Medical devices like blood pressure monitors are already wirelessly connected and on a permanent basis. There's no need to pair with Bluetooth or repair them when the software updates. These are all obstacles that can prevent some people from accessing remote care due to their disadvantaged circumstances. By eliminating these barriers and simplifying the system to work in kiosk mode, it is possible to take quite a complex tablet and turn it into a very simple medical device that virtually anyone can use to support their health at home. A myriad of health and wellbeing services can be delivered over the system, and because the system provides low-cost equity of access, it's perfect for priority populations who might otherwise struggle to access these services. By making it easy, we also reduce pressure on clinicians and administrators who see a huge reduction in the need for tech support. Many of the people who could benefit most from telemonitoring are the same people who are least equipped to take advantage of it. That's the injustice that equity-led telemonitoring addresses. We need to have an option for people who can't access great new digital models of care with their own smartphone, laptop, or computer. When we do, as St John has done, we see very high levels of engagement, strong compliance with treatment plans, and early interventions leading to better outcomes. I'll leave the St John team to discuss more about their project, but suffice to say, we have seen thousands of readings and thousands of consultation minutes with patients because St John have made access to their telemonitoring service easy by taking an equity-led approach from the start. Why is equity-led telemonitoring important? One way to answer that question is to talk about who benefits from equity-led telemonitoring. Spritely operates at a very important but sometimes hard to reach intersection within the health sector, where people who are disengaged with the health system struggle to manage chronic illness. According to Manatu Haora, long-term conditions pose a major challenge for the New Zealand health system. The prevalence of long-term conditions is high and rising, particularly for Māori and Pacific people who experience the onset of disease at a younger age and face a higher risk of complications and early death. Long-term conditions lead to significant social and economic impacts, both for individuals and their whānau, and for the health system and society in general. That comes from the Ministry of Health website. So it's a very big issue. It's not uncommon for people with long-term conditions to also have poor access to devices and limited experience of technology. So by enabling new models of care to manage chronic illness at home and making it easy for this particular group to participate, we hope to reduce pressure on primary and secondary care and create a great experience for people that don't regularly access health providers, an experience that is accepted by patients and builds or renews their trust in the health system. Remote patient monitoring can increase access to care and hasten interventions. It reduces admissions, improves GP and ED capacity, and improves patient health. There's an abundance of international research out there to support that. I think our country needs more accessible telemonitoring services to meet increasing healthcare demands, particularly for priority populations from disadvantaged groups. By eliminating some of those barriers, the ones I described in the previous slide, we can ensure low-cost equity of access. So where does it all fit, particularly in light of the current reforms? Well, the Interim New Zealand Health Plan 2022, known as Te Pai Tata, sets out the first 2 years of health system transformation to improve the health and well-being of all New Zealanders. It builds on the 4 pillars of our new health system outlined in the Paora legislation, including the first pillar, which is health equity matters for everyone. Te Pai Tata identifies 6 priority actions that will deliver key shifts in health service delivery. Now, we don't have time today to talk through all of them, unfortunately, but I would like to highlight number 5, which states, develop greater use of digital services to provide more care in homes and communities. When you combine this with that first foundation of the Paora legislation, that health equity matters for everyone, you very quickly see why equity-led telemonitoring is such a priority for the health system right now. How can we develop greater use of data and digital services in homes and communities if many of those homes and communities lack experience with technology and access to devices? If we want to fulfill our equity obligations under the new Paora legislation, then we must have an equity-led option for people who qualify. It doesn't have to be for everyone, but it is the responsibility, in my view, of the health sector to ensure that it is an option for people who need it. At Spritely, we developed our equity-led telemonitoring system to help retirement villages screen for COVID-19. It was developed out of a COVID-19 response. It helped manage residents who were symptomatic or exposed to people who were symptomatic. And now we help healthcare providers remotely manage a whole range of treatment plans for a whole range of priority population groups. Now, where is it being done? For the most part, it's happening quite locally and potentially you could say in isolated pilots. But some of them do exist with potential to scale nationally. One example comes from an organisation that is speaking right after me. So in just a few minutes, you'll hear from St John about pioneering an innovative service that uses equity-led telemonitoring. They're not the only ones, but they do offer a fine example, in my view, of how this kind of service can transform people's lives by proactively helping them to manage chronic illness before there are serious complications. The Manaaki Mamau program, which has been partly funded by Manatu Haora, translates as care from a distance. It is for Māori and Pacifica with hypertension. Recent research in New Zealand concluded that Māori and Pacifica are 3 times more likely to die within 1 year of their first heart attack or stroke than Pākehā, and a leading cause of this is uncontrolled hypertension. St John is now working directly with GPs to identify at-risk Māori and Pacifica people and refer them to their monitored hypertension care service. The St John clinical team confirms the treatment plans with the referring GP and escalates any concerning trends and sends monthly health summaries back to the GP. I really look forward to hearing from Malcolm and Nicole about the program very soon. And I'd like to congratulate the whole St John team for their initiative and their effort to conceive and deliver such an innovative and meaningful project. Well done, St John. I'd love to hear about more examples as well. We can all learn from the experience of others, as yesterday's health equity workshop demonstrated. I think if we can all achieve greater cooperation around equity-led telemonitoring, then that will be a great outcome from this conference. There are already lots of organisations out there considering how equity-led telemonitoring impacts the ethics of delivering new models of care over data and digital. So when will it be able to scale up? Well, we need stable conditions for business to operate in, and we need to create long-term predictable programs that clinicians feel confident referring to. So that means longer-term contracts over several years. Short-term pilots make it hard to invest what is needed to develop new models of care for the health system. Where it is necessary to start with a pilot, establish clear criteria and supported pathways so it's possible for those pilots to become a permanent part of the health sector. Offer multi-year funding if certain objectives are achieved. That motivates everyone to look beyond the pilot. Link pilots with academic researchers from the start so that when pilots are planned, there will be independent evaluation of their effectiveness. And funding for this shouldn't come out of the total pilot cost. It should be separate. It should be extra. Separate funding for research helps to ensure independence, and it builds extra capacity for research so that people running the pilot aren't competing with people researching the pilot for the same funding allocation. Longer-term contracts enable longer-term thinking and planning. This can enable meaningful investment in people, processes, and, of course, technology, including integrations that improve quality and efficiency of care. It also enables wider interoperability, meaning that equity-led telemonitoring can be provided as an option for a broader range of treatment plans. Equity-led telemonitoring programs that are well established and have a long history also generate more longitudinal data than short-term pilots. So over longer periods, we can start to determine the true social and economic impacts of those services. I believe that backing our most promising pilots to become long-term programs that are well-researched will have a greater impact on the health system than simply funding an infinite number of short-term pilots that are quickly discarded. This knowledge will enable us to scale up wherever there is the greatest impact, helping to reduce pressure on the health workforce and improving patient health outcomes and patient experience outcomes in a targeted way, focusing on priority populations. Thank you. I would love to chat more with anyone that thinks equity-led telemonitoring could help them and their patients to have a better quality of life with better health outcomes.